have more guidelines. Now, a lot of times our patients with diabetes, even if it is type 2 diabetes, they need to go on injectables, which is not the most acceptable treatment option for patients, but they need to have it. The injectable may not be just insulin, it can be GLP-1, and actually our preference is GLP-1. And we try to start it prior to insulin because it is hyponeutral, it promotes weight loss. Weight is the main problem in type 1 diabetes. If GLP-1 doesn't help improve the HbA1c targets, then we can add basal insulin. And from last week, you remember basal insulin was the long-acting insulin. If the patient is already on GLP-1, then obviously we go straight on basal insulin, or the other option is that you could use combination of basal insulin and GLP-1 in one fixed ratio combination pen. So we have got new pens in which you would have a GLP-1 plus a basal insulin together, and that can avoid the necessity of multiple injections in certain group of patients, and these also prevent the weight gain associated with basal insulin. If the HbA1c is still high despite these steps, then the next step is usually prandial insulin. Prandial insulin is the bolus insulin, or the insulin that's supposed to be given before meals. That is the rapid or short-acting insulin, as we discussed last time. We can always start with one dose and then up titrate in a stepwise way to make sure that the target glucose readings are achieved. Again, basal and prandial insulins can be mixed in the same pan, so you have got pre-mixed formulations or biphasic insulin, but there's high risk of hypoglycemia and weight gain with those combinations. The best insulin regime for poorly controlled diabetes is always basal bolus insulin regime, as we discussed last time. So if you do have someone using multiple therapies, remember type 2 diabetes is very patient-centered. It is involving stepwise approach and use of multiple combination therapies to achieve the goals for the patient. So your patient may be on SGLT2 inhibitor. This is just like a traffic light system for you to remember. If you want to use SGLT2 inhibitor for someone with established disease, this is fantastic drug to add on. We've got fantastic data, but remember, this drug is associated with euglycemic diabetic ketoacidosis because we know this drug can increase the glucagon levels, which can impair the ratio of insulin and glucagon and lead to DKA even if the patient is type 2 diabetic. So we instruct them about sick day rules, anything that would increase ketones, for example, starvation, fasting for religious purposes, or if they're having a lengthy fast for an elective operation, we hold off SGLT2 inhibitors. Metformin, absolutely fine whenever you're intensifying with injectables. There is no problem with metformin at all. DPP-4, again, we must remember that incretin-based therapies, if you're using, you just use one, either DPP-4 or GLP-1. So if you're going on an injectable GLP-1, you don't want to combine it with DPP-4 inhibitors. So if someone is on sitagliptin or linagliptin, and you want to start them on liraglutide, then you must make sure the gliptins must be stopped. The sulfonylurea. So sulfonylureas are drugs which can provoke hypoglycemia. If you have got a patient whom you're starting on insulin, and it is basal insulin, I would always suggest either consider stopping sulfonylurea, or if it is still required, you reduce the dose by 50%. And I would never, ever use a sulfonylurea with prandial insulin or pre-mixed insulin, because there's no point. Sulfonylurea just releases the insulin from the pancreas. The response of subcut insulin becomes variable and extremely unpredictable when combined with sulfonylurea. You can use it with basal, but not with prandial, never with prandial. The glitazones, again, these are less favored drugs these days. We try to stop them when we are commencing on insulin, because their role is to make your body sensitive to your own insulin. So there's no point continuing this drug, which will also make them put on weight and cause osteoporosis and fluid retention and heart failure. So not a preferred choice. So if you have a patient who has got cardiovascular history, in that case, intensification should ideally be with GLP-1 receptor agonist, which would be preferred over insulin. But if the patient has got symptomatic hyperglycemia, again, if they have got significant renal impairment, the only choice you would have would be insulin, because the majority of drugs cannot be used alongside extremely low EGFR, with the exception of SGLT2 inhibitors, which I think would be beyond the scope of this audience, and that is something which endocrine registrars should know, because newest trials are showing SGLT2 inhibitors can prevent diabetic nephropathy of your mobile. If you think this concept is fascinating or helpful to you, don't forget to subscribe to our channel, Endocrinology and Diabetes Simplified. I'm Dr. Jawad Bashir. I'm a consultant endocrinologist who has dedicated time to make medical education simplified for my trainees. If you've got any particular topics in endocrinology that you want the videos to be made, please scribble them in the comment section. Thank you.